はい、どうも皆さん、こんにちは。というか、日本の皆さんに
Good
とって
morning
は、おはよ
for
うございますです
Japanese.
ね。もし世界の方々で見
And
ていた
if you
だ
are
いてい
joining
るとすれ
from
ば、
around the
こんば
world,
んはでしょう
good
か。
evening,
はい、
maybe.
どうもこんにちは。そしてこんばんは。
Hello, good
ワンステッ
evening.
プの長谷川克夫です。
I'm Kazuo
今日
Hasegawa
は、
from One Step. Today,
海外の患者会
we
の方
have
々と
the
共に
leaders
話す、
from the
競争
overseas
の始ま
patients
りと
group.
題した対話をしてみたいと思います。
Today,
よ
we
ろしくお
have
願い
the
します。
discussion time.
はい、
Um,
早
it
速
is
もう始めていきたい
the
と思うんですけ
beginning
ども、
of co-creation, and we'd like to
ですね、
kickstart this
皆
seminar.
さんに、では今日の説明をしていきたいと思い
Let
ます。
me just, introduce
画
you
面共有
today's
ですね。
agenda. Please allow me to share my screen.
はい、どうでしょうかね。映ってますかね。米田さん映ってま
Now,
す？
are
大
you
丈夫
able
か
to hear? And also, are you able to see the screen?
な？大丈夫ですかね。
Is everything
はい、
fine
じゃあ
with
このま
you?
んまいきたいと思います。
Okay,
今日
shall
は
we
競
continue?
争の始まり、コークリ
The
エーションの
beginning
始ま
of
りであります。
co-creation.
11月は肺がん
Today
啓
is the
発月間ですので、
beginning.
待ちに
And
待った
November
海
is the
外の
month
患者
for
会
lung
の方
cancer.
々と
So
お話しし
much
ていきたいと思
anticipated
います。
the talk with
3つの患者会
overseas
に来て
patients
いただき
groups.
ました。
We have invited three
EGFR、
patients group,
ALK、KRAS の
EGFR,
患者会の
ALK,
方々で
and
すね。
KRAS
後ほど細か
groups.
く紹介していきたいと思います。
Will
ではですね、
have their
聞い
presentation
てらっしゃ
later.
る方々に
And
今
to
回
our
の
listeners,
翻訳、同時通訳について説明して
we'd
いきた
like
いと思い
to
ます。
explain how you can
まずですね、
utilize
この
simultaneous
会議は
interpretation.
同時通訳を
This
介し
meeting
て行われま
is
す。皆さんの、
conducted through
そうですね、ズームのところ
simultaneous
に通訳
interpretation.
ボタンがあると思うんですね。
You
ち
have
ょうど右下にあ
interpretation
る、
button
地
in the
球儀の
right
マークです
bottom.
ね。
You can see
これが
the
通訳ボタンです。そこを押すと、
globe
日本
mark.
人であれば日本語というところ、
If
英語
you
で聞
want
き
to
たけれ
listen
ば
to
英語というと
Japanese,
ころを押して
please
ください。
choose
そうす
Japanese.
ると、お
And
風呂の通
if
訳
you
の
like
方
to
が出て
listen
きて
to
ですね、
English, please
私たち
choose
の声を、
English.
英語
And
は日本語に、
in
日
this
本語
way,
は
you
英
can
語にし
utilize
てくれます。
in
はい、
simultaneous interpretation service.
で
If
は、
the speaker
始め
speaks
ていきたい
in
と思います。
Japanese, you
ま
will
ず
hear
は
English.
ワンステッ
Okay?
プ、私たち
And
の患者
now,
会の紹
we'd
介を
like
してい
to
きたい
start
と思いま
now.
す。
First,
私
allow
た
me
ちの
to
紹
introduce
介です。
our,
ちょっと
I
まず
mean,
は
patients
最
group
初に
called
この
One
左
Step.
の
You
キャラク
can
タ
see cute
ー、を紹介したい
character.
と思います。ワンステッピちゃんというふうに言います。
Its name is
これ
One
は、
Steppy-chan. Chan
私
is
たち
always
ALK
given
の
to
患者さんがいてです
Japanese
ね、
names.
もう亡くなっています。その方がで
This
すね、
was
作ってくれました。
created by late
ここに映
patient
ってるのはひよ
already
こなんですね。
passed away.
ひよこは、
It's a chick.
日本語で言うと赤ちゃんの意味を指します。
Chick
つまり病気になった
stands for
ばかりの
baby.
もう赤ちゃん
That
同然の
means those who were
よちよち歩
just
きの
been
人間患者だけれど
diagnosed.
も、ワンス
He
テップ、一歩を
started
強く踏み出すぞといったようなキャラク
taking
ターであります。
steps. That's why it
私たち
says
はとて
one
も大
step
事に
in
しています。
Japanese. This one is trying to make his or
は
her
い、では
first
続いていきま
step
すね。
as a patient.
簡単に私の紹介をしたい
Please
と思い
allow
ま
me
す。
to
私は
introduce
長谷川
myself.
和夫
My
です。
name is Kazuo
54歳
Hasegawa,
です。
54 years
この写真
old.
は病気になったばかりの写真ですね。
This photo was taken
7
right
歳と
after
5
I
歳の
was
子供がいました。
diagnosed. I
はい、
have
で、
a
ステー
very
ジ
young
4と
children,
言われてで
7
す
and
ね、
5. I was
なんとか
diagnosed
生き延びて
stage
今は
4,
15年ほ
but
ど経っていま
I've
す。
been surviving 15
ちょっとゆっくりめ
years
に喋ってみ
since
ます。
then.
はい、同時通訳し
I
てみ
am
ます。
trying to speak slower.
そして簡単に私の、治療のヒストリーを
And
説
this
明
is
し
my
ます。
treatment history.
私は3つの治療法、化学
I
療法、放射線療
received
法、手術、
radiation
全部して
therapy,
います。
chemical
なかな
therapy, and
か15
surgery.
年前ですので、
It's
ドライバー遺伝子
15
は、
years ago.
EGFR と
Therefore,
ALK しかありませんでした。
that driver
そ
and
して私
genes
はそのどちらに
only
も入ら
identified
なくて、
for
普通のキラキ
EGFR
ラ
and
の抗
ALK.
がん剤をしてなんとか生き
But
延び
I
てい
didn't
ます。
fall in these two, so I got the chemical treatment ordinary as platinum.
ワンステップの紹介をしたいと思います。
Let me
2015年
introduce
に始まりま
our
した。
group, One Step. Started it in
そして今、会員は
2015,
1万
and the
2000人が
number
います。
we have 12,000 members
ここにちょ
now.
っと抜けてるな。私たちが一番大切にしている言葉があ
What
りま
we
す。
value most
それは勇気ですね。
is courage, although it's
はい。
not here. It
そ
says
して
courage.
この勇気、なぜ勇気なのかという
Why
と、
courage?
私たちの患者会にいるのは進行がんの患者会なんです
Those
よね。
patients who
命の
belong to
限り
our
をみん
patients
な
are
告げ
in
られています。
progressive,
それで
you
も
know,
人は満足
cancer.
いく人生
Therefore,
を送ろうと思っています。
everybody experienced
そこ
being
に必要
told
なも
that
のは
your life is
私は
limited.
勇気ではないか
So,
なと考え
but
て
we
い
want to
ま
live as
す。
much as possible. Therefore, what is
そのた
required,
め
I
私たちの
believe,
活
is
動は
courage.
この勇気を
Therefore,
生み出すこと、勇気を
the
支えること、そののみ
activity
に
is
絞られています。
concentrated
年金を作っ
on
たり、
doing
教育をしたり、
exerting
ア
our
ドボケートをしたり、
courage,
これが
making
私たちの内
community
容です。
and
ちょっ
the
と具体的に紹介していきたいと思います。
in this way going forward
私
in
はガイドラインの
collaboration.
参加とガイドラインの策定にも関わったり
I am also
していま
involved
す。
in building guidelines.
アクションをもう少し紹介すると、
Let me introduce
患者が
actions
提
more.
案して行った臨
Patients
床試験というものもありました。
funded proposed clinical tests also was realized.
そして調査を最近は多くしています。
In
特
these
に今
days,
一
we
番注
do
目
lots
しているの
of
は
researches,
SDM ですね。
and
シェアド
we
デションメイ
focus
キングに関し
SDM,
ての調査がすご
share
く激しくやっています。
decision making.
今
We
3
are
つ目にチャレンジ
actively
しようとしているところです
working
ね。
on the third
特
one
に
now.
EGFR は、
Especially
一
EGFR
時治療で
is
今日
the
本では4
primary
つの選択
treatment,
肢。
and there
アル
are
クで
four
は一時治療
options.
は
ALK,
アレクチニブなのか、それともロー
ALK
ラチニブなのか、
chinolop for the first
どっ
one,
ちなんだっ
lorlatinib
ていうような議論が
is the
あり
second
ますよ
one.
ね。 そういっ
Which
た
is
ものを
better?
どうやっ
We
て決めればいいのか、
having
そ
discussion.
ういったこ
How
とを
can
調
we
査していく
choose
という
either
紹
of
介です。
them? That kind of research we are doing.
そしてまた、治験
And
に関しても
also,
とても興味を持ってい
clinical
て、
trial
治
is a
験に
field we are
参加
very
する、
much
参加
interested
でき、
in.
治験を主治医から紹介される人とさ
There
れ
are
ない人では
people
ど
who
んな
are
違いがあるのだろうという
introduced
ことは
a
去年、
clinical trial
今年か
by
今年発表させていただきました。
physicians, their doctors, or those who are not. What's the difference between them?
そしてスティグ
We
マのリサーチ
conducted
もしてい
that
ま
kind
す。
of research. And also, we
ここ
conduct
まで私たちのアクション
stigma
を紹介
research
しま
as
した。
well. I have just briefly introduced our actions.
そしてですね、
And
今日、ここからが
today,
今日の本題になります。
this
な
is our
ぜ
topic
私
today.
が海外の
Why
患者
or
会の方
how
々をお
I
招きして会議をしようと思っ
decided
たの
to
か
introduce
に
the
ついてお
overseas
話しし
patients
ようと思い
group
ます。
and have a discussion. I want to tell
始
you
ま
the
りは
background. The
2018 年
beginning
の
was
世界肺がん
World
学会の
Conference on Lung Cancer
場です。
2018.
トロントで行われました。
It took place in Toronto, Canada.
そこでは
And on that occasion,
ドライバー遺伝子ごとに患者
based
会
on the
が組織さ
driver
れているという
genes,
ふうに紹介され
the
ていました。
patients groups are being
ロス1、
formed.
アル
That
ク、
was the
エクソン20、
introduction.
EGFR、
Loss
ネット
1,
と
exon
こんなふうに
20,
紹介されていたんですよね。
like
そし
that.
てその患者会が国
And
をまたがって
the
組
patients
織
group,
されていま
these
した。
patients
英
groups
語圏
are
でつながっている
organized
ということですね。
across,
はい、
in a
これ
cross-border
は一
way
体なぜなんだろう。
in English-speaking countries, especially. Why is
そ
this?
の時には治験を加速するためだというふう
I
に説明
learned,
されていました。
the
ちょう
reason was
ど
to accelerate
その時のス
clinical
ライドで
testing.
はエクソン
According
20の患
to
者会
the
が
slide
行
I
っていって
saw
ど
at
ん
that
どん
time,
臨床試験
the
を加速させているんじゃな
exon
いかと
20,
推測されていました。
it was assumed that
私
this
はこの
patients
こと
group
に
are
とても驚かさ
accelerating
れま
the
す。
clinical testing, and which was really
明
surprising
確
to
な意
me.
思を感じるんで
They,
すね。
I felt the clear decision,
ド
I
ライ
mean
バー遺
the
伝子、肺がんの
intention,
ドライバー遺伝子、
the lung cancer
ドライバー遺
driver
伝子やアル
genes
クだったり、ネッ
such
ト
as
だったり
ALK
は、すごく
and
もう数が
MET,
少ないですよね。
it's still
人数が
very
少ない。
small in
なので、
number.
新薬
Therefore,
は待ってい
the
ても
new
出てこない。
drugs, even if
だ
you
ったら
just
自分たちで参加して、
wait, they do not
えー
come to
新薬を
you.
作ってし
Therefore,
まおうじゃないか。
they have
そういう意思を
action
感じてい
to
ます。
move on their own to
治
make
験を加速させ
the
る。
it's
自分たちで
possible
新薬を
to
作るん
come
だ
up
とい
with
う明
new
確な意
drug.
思を感じたん
I
ですね。
felt the clear
とても
will
それ
to
は
make
私に
new
影響
drugs.
を与えま
That
した。
really
そし
inspired
て先
me.
ほどのような、そして私たち
And
のアクションにつながっていきます。
this has led to the action I have just described.
では、ここからがですね、
Now,
今日の本番ですね。 3つの患者
shall
会
we
を
move on
お呼びしています。
to
こ
the
の患者会の
presentation
方々
by
のお話を
overseas
聞いて、
patients groups?
それぞれ聞いて、最後にディスカッシ
And
ョンをし
we
て、
will have
今日
discussion in the
今日を
end.
進めてまいりたいと思います。はい、よし。はい。では、ここからですね、
So
早速3
from
つの
now
患者
on,
会に
I'd
出
like
てきていた
to
だいて、
invite representatives
一つ一
from
つの
those
団体の
three
プレゼンをしてい
patient
て
advocacy groups to
もらいたい
receive
と思います。
presentation from each
まず
one of
は
them. First of all,
EGFR レジスターズの
EGFR
ジルさんで
registers,
す。ジルさん、
Jill
画面
san,
オンにお願いできますか。
Jill, could you turn on your video?
どうもこんにちは。
Hello, Jill.
こんにちは。
Hello,
Hello.
thank you for having me. It's such an honor to be here.
はい。では、私の方からジルさんを少し紹介したいと
So
思います。
first of all, let me introduce yourself.
アメリカの
In the
EGFR
US,
レジスターズのを
she
率いてい
is
る
the
ジル・
leader
フェルドマンさんで
of
す。
the
ジルさ
EGFR
ん自身も
registers in the US.
EGFR の
Miss
陽性
Jill
の患者さんで
Feldman,
す。
she
で、
herself is a
ジルさん
EGFR
を
positive
一言で
patient.
言うとですね、
And to summarize
リーダーです
who
ね。
she is a
リーダー
leader,
という言葉
true
が
leader.
一番当てはまると思います。
That's exact
世
word
界
I
肺がん学会
always
に行っても、もう
think.
いつも忙し
When
く
I think about
動いてるん
her,
ですね。
she's so
そん
busy
な
in
ジルさん
Congress
の患者
meetings
会の
everywhere.
活動をぜひ
And
紹介してもらいたい
now
と思い
we'd
ます。
like to listen
では、
to her
よろ
about
しくお
her
願いします。
activity. The Jill, the floor is yours.
Thank you. Thank you again. Thank you for having me. It's truly an honor. And I definitely want to share the EGFR resistors, but Mr. Hasegawa, your story brings me back to where lung cancer in the United States was when I started in advocacy. So a little bit about my story. It didn't start when I was diagnosed with lung cancer. It started when I was 13 years old and I lost my dad and 2 grandparents to lung cancer. And then in my 20s, both my mom and my close Aunt Dee Dee died of lung cancer. Now, during that time in 2000, 2001, I tried to find a support group, a walk, an event, an organization. There was absolutely nothing in the United States back in 2000 to support people impacted by lung cancer. And I always say coincidence or fate. The first organization in the country dedicated exclusively to lung cancer was founded in my community in 2001 by 7 people diagnosed with lung cancer. I got involved shortly after it got off the ground, 6 months after it got off the ground. But by then, I only was able to meet 3 of the people who founded Longevity. But I would not be the advocate I am today if they had not had the courage to start this organization while they were fighting for their own lives. I don't think the lung cancer world would be where it is today without them as well. So I like to always honor them. But I got involved in advocacy and I did what I could to educate myself and be an advocate. And while doing so, I was diagnosed in 2009 at 39 years old with EGFR positive lung cancer. They had just started testing for EGFR and KRAS. And my kids were 6, 8, 10, and 12 at the time. Their only association with the disease was death. They were scared, and my biggest fear became reality. I was following in my family's footsteps. And as you can see here in 2009, there still wasn't any promising research that convinced me my path would be any different than theirs. As we all know, it's a whole different lung cancer world now, and I've had a front row seat to the evolution of biomarkers, which has led to this revolution of treatment options, the number, the variety. But one thing remains is that not everyone benefits from these advancements, and that's something that needs to change. But what really I saw in the shift in the community, if you will, the advocacy community really happened with a rise in social media. Back in 2014, 15, people started finding each other online. When you are diagnosed with a cancer, and especially even with the common mutations, they're not the most common type of lung cancer. You're desperate to find somebody else like you. And that's really how ALK and ROS1 were the first two to be founded in 2015. And it's both patients and caregivers and loved ones that found each other. And so the EGFR resistors, truth be told, the other founders were together first, and they took them a while to convince me to join them because I was hesitant to do another nonprofit. But in 2017, and really our aim was to engage people, to educate them, and to empower them. And we wanted to build a community of survivors, patients, caregivers, with the goal of raising awareness and improving outcomes for people with EGFR positive lung cancer. And I put on here the 4 different methods that we use to do that. But I want to acknowledge that we lost Terri and Anita in 2019, and then Alan in 2022, I think, or 2021, Ilde in 2022, and Ivy in 2024. And again, if it weren't for them, we wouldn't be where we are today. So I, honor them in any way that I can. But now we're a global community of over 100 countries. We have at least 7,200 members. And what we've really seen change within the community is the growing stage and early population, with people who are diagnosed with stage 1 and 2, but they're going on treatment after having surgery. And it's great to see more of diverse stages being a part of this community. And I think all of us, our purpose is to provide hope, to support people, to educate people, to empower people, and to connect. There is nothing like connecting with others in the trenches, people who get it in a way that no one else can who hasn't lived it. I say to this day that no amount of therapy could have helped me through my losses to lung cancer like the community did, and my own diagnosis. But, I want to share just some of the programs we've seen that, have driven impact. And we have done a lot of creative ways. We've worked in a lot of creative ways to get these done because we weren't a nonprofit. But our webinars and Ask the Expert series, those are our community cannot get enough of them. We talk about what happens after resistance and progression. And we've talked about the hot topics that everyone wants to learn about: brain metastases, leptomeningeal disease, the role of surgery in stage 4 cancer, advanced stage cancer, oligometastatic disease. And we also try to educate on, kind of the myths of clinical trials. And speaking of clinical trials, the one thing we have is a living clinical trial document. And we have volunteers who actually try to keep up to date on all of the clinical trials. And they're broken down per line of therapy, per EGFR mutation. And we try to get the information from the companies as the trials are developed or things change in them, but we also do our own research, and that has really become a big lifeline to our community. Project Priority, one of the first things we did was we wanted to understand the lived experience. We had the data from all of the research done on demographics and risk factors, but there was everybody believed that the lived experience of people on targeted therapies was wonderful and normal and so much better than chemotherapy. And we really wanted to understand that. So Project Priority was an IRB approved survey. And really what we learned is that our healthy community still struggles and still needs support in areas such as side effects, financial, access, even mental health. And so we really use that data, and it's open source, and encourage other researchers to use it, which they have. And we created a dashboard so that anyone in our community can go onto the dashboard and be able to read the data. It's presented in a way that's really digestible, and it's still a work in progress. But really, a lot of the support is through the closed Facebook group. And this year we will have our first, next week, Friday, actually, we'll have our first in-person summit in Chicago. The planning started for this in 2019 and just never picked up after COVID. So I'm really happy that it's picking up. And we have these downloadable fact sheets, which, are about EGFR. But one of the new projects that we're working on, and I don't have the slide on here, but is our digital education videos. And I think, not everybody can pick up a sheet of paper and read it. So I'm really excited for these videos to be created. But one of our other goals, and something we're very passionate about, is accelerating research. So except for Project Priority, which was 2019, but since 2021, we funded over $1 million in research, and through partnerships with other organizations. And when I say partnerships, this research was patient-led, patient-funded, patient-driven. But because if not being a 501c3 nonprofit, we couldn't raise our own money. So we reached out to the larger organizations and said, hey, we'd love to work with you, use your fundraising platform so our community can raise money, and use your science team to help us vet through all of the research proposals. And that's exactly what we've done so far. We actually have one more award, a $300,000 award we're going to be announcing soon. And that really is important. And this is the epitome of patient partnership, if you will. This is the epitome of raising $25 at a time, $100 at a time. And the motivation and the passion from our community is how we've been able to do this. None of this research would have happened if it weren't for our community. And And one other thing I want to talk about that I think has been like a huge success with the EGFR resistors. When we first got off the ground, somebody reached out to us and said, hey, I just did some continuing medical education in EGFR, and I'm curious about what your group is doing. And so we had a conversation, and this company ended up securing funds for us to have a think tank at ASCO in 2018, which what we did was we brought together thought leaders in the EGFR space. And as I mentioned, we already did a project priority to understand the lived experience from patients, but we wanted to know what the researchers, clinicians thought were the unmet needs from their point of view, and came together. And there was a lot that we were, there was a lot that we were able to, I'm so sorry. I don't know why this is coming through. It's on Do Not Disturb. There was a lot that we learned, but one of the things that the main message that they came through with was to really like help early career investigators early in their career and be able to, foster collaborative efforts early. So what we did was we started the EGFR Resistors Research Summit, and we just had our 7th one this last week. And we bring together about 15 to 17 early career investigators. What they do is they will submit an abstract or a concept. It doesn't have to be complete surgery to apply for the program. We have about 5 or 6 judges that are like faculty. I am so sorry. Why is this doing this? We have 5 or 6 faculty judges that are experts in the field as well. And they also serve as mentors to these early career investigators. And so they come together, they present their data, they get feedback from the mentors. We have these breakout, like roundtable discussions. They get talks on grant writing, they meet each other, and it really is an incredible experience for them. And I've seen what's come out of it. And in fact, there's been further collaborations from it that have been unbelievable over the years. And so every year after it is over, I just got a couple of emails today from people that were, talking about what their plans are moving forward, who they're collaborating with, ideas for other things. So it's really been, I think, a great opportunity to move those, to help people early in their career. And now more than ever, especially in the United States, that is really, really important. And so as of January, we did become an official independent nonprofit, and it was important. It's important so that the organization is sustainable. I don't know how we did it without being a nonprofit, but it's, it'll give us greater flexibility to be able to drive more patient-centered research and really expand programs and support for our community, amplify our voice, other opportunities. We are still working closely with all of our partners that we have worked with. It may be a little different now. This new project we're funding, they will match us dollar for dollar. So that's actually a great business proposition. But we really just are going to be able to give more to our community, and that is the goal. And our vision forward is to expand global patient engagement, really to collaborate globally and elevate underrepresented voices. And I think that is an opportunity globally to do that. I think it's an opportunity for early stage young adults, all of them, all of those areas. It's not easy, but we are committed to that. And we really want to continue to support the early career investigators. They are the future they are our future. They are our lifeline. And so we really want to be able to build something that's sustainable and accelerate research on urgent and unmet needs. And when I say unmet needs, yes, research for treatment, but there are other unmet needs. There is survivorship care to help people live with uncertainties, with unmet needs when it comes to side effects or financial or familial. We want to support loved ones. And so there's a laundry list of unmet needs, but we will start with where we can there. And so just want to say thank you to our motivated community. They are really, truly an incredible group of people. And I look forward to meeting some of them this weekend. And of course, honor our founders, because if it weren't for them, we wouldn't be doing what we're doing today. So thank you again. I really appreciate the opportunity to talk, and I apologize again that my children were calling in like nonstop, and I have my computer, I have everything on do not disturb or focus, and so I don't know how that happened, but I apologize.
今、Zoom の機能はと
As
て
a
も
matter of fact,
素晴らしくて、なんかそういった
Zoom
ノイズ
function
は
is
私
very
たちに聞こえ
good.
ないようにな
We
っているんです。
really do
なの
not
で、
hear the
電話の音は
noise.
聞こえ
So
ませんでした。
please do not worry.
大
We
丈夫
didn't
です。
hear
はい。
any,
ありがとうございます。
telephone
素
ringing.
晴らしい講演ありがとうございます。
You just heard me stuttering
Thank
over
you.
my words. I'm like, but thank you.
いえいえ、大丈夫です。
That's fine.
ど
That's
うでし
fine.
ょう、今これを聞いてくださっている方は、
So
日本
what
の
about
患者
the
さん、もしくは
listeners,
利用者の方々が多いと思います。
caregivers, patients listening?
海外の、アメリカの患者会が、
You
そう
just
ですね、
heard how the
自分たちの組織を
US
発展させ
patient
て、
advocacy
そして
group
患者ドリブンで、
developed
患者主
their
導でこう研究を行おう
organization
としている、
in
そんな姿
patient-driven
が
way
見て取れ
to
たのではない
really
かなと思っています。
conduct
日本の患者会
patient-driven
が分か
studies.
ち合い、コミュニティの
In
方を重
Japan,
視する
we are focusing on
方が多
community
いんですね。とても
mainly
ジルさんのお話
to
は印象的な
share.
のではなかった
But
か
I
なと
think
思います。
I think Jill gave us
で
a
は
very
早速ここからですね、
impressive
10分ほどジルさん
presentation.
に質
So
問してい
now
きたい
we'd
と
like
思
to
います。
spend 10
よろし
minutes
いですか？
to ask a question to Jill. Are you ready?
OK ですか？ありがとうございます。
Thank you very
ジル
much.
さん、
Jill,
ジルさんのスライドにもありましたけども、
in your
ド
slide,
ライ
I
バー遺伝子ごと
saw
の患者会という
a
のは、
patient group
もう
by
今、もう
driver
13個ぐらいあ
gene.
るんですね。
You
結
have
構
you
少
already
数
have
派遣
13
の
in the
患者会がありま
US,
したね。
and you
どん
also
どん
have a
こう細分
patient
化されてい
group
る状況
for
があるということでしょうか。
NSCLC. So it's more kind of meticulously grouped by small categories. Is that right?
Yes, so that, yes, it is right. It's some of the biomarker groups actually are not specific only to lung cancer. So some of them that say the mutation plus NSCLC, mean they're looking at that mutation or that alteration in non-small cell lung cancer. But the different biomarkers are definitely kind of categorized by whatever biomarker it is. Not all of the groups are nonprofits. Not all of the groups, fund research or accelerate research, but all of them provide a community. All of them provide, the support and the connection and the networking with each other and the education for the most part. And there, I put the small cell smashers up there. While they're not a biomarker per se, they are within the lung cancer space. They are, not the majority. They're, actually more of a rare type of lung cancer, and they have unique needs as well. And so that's why I put them up there as well.
はい、ありがとうございます。
Thank you very much.
私は世界肺がん学会に行って、
So when I
ワンステップという
participated in
患者会をやっています。
World Lung Cancer
あなたの患者会は
Association,
どう
and
いう
I
のですか？
organize
ニューですか？って聞かれることがあるん
One
ですよね。
Step, and
つまり
sometimes I
私
ask
たちには
your
いろ
patient
んな
group is
ALK、
old
EGFR、
or
KRAS、 いろ
new,
んな
because
肺
there
がんの
are
患者会という
various
肺
patient
がんの人た
groups
ちが入っていますので、
uh,
今それは
with
オールド
different
オールドタイプだというふうに言われて、
biomarkers like
ちょっとびっくりしている、そん
ALK,
な状況でもあります。
EGFR, and
ただ
it's called
こう今
old type,
ジル
and
さんの
which
ような
really
一つ一つの
surprises
バイオ
me.
マーカーごとの患者
But
会の方が
but
やはりそ
biomarker
の
based
声を直接届
patient
けやすい
group
というのが
can
やっぱりあるので、
better deliver actual
バイオマーカーご
voices
とに
of the
ま
patient.
とまっている
That's
という
why
流れなんでしょうか。
I think that's why that is a primary purpose you organize those patient group by biomarker. Is that right?
Yes, it is interesting. When I first got involved in lung cancer, there was no such thing as a biomarker. And I consider myself still first and foremost a lung cancer advocate. I always will be. I'll always advocate for all lung cancer. And I truly believe that all of the work that I do will benefit, come back and benefit EGFR, but hopefully benefit the other biomarkers as well. I think there is no competition. We have nothing to compete against, nothing to compete. But so what's really important about the groups, I think, is that, again, unique needs. We are on different treatments. So we can talk about treatments that are specific to that biomarker. And you can fund research that is specific to that biomarker. You can hear from experts who are specific to that biomarker. So I think I would equate it to any other, almost like in lung cancer, you have non-small cell and you have small cell. If you're diagnosed with non-small cell, it's not that you don't care about people who get small cell, but you want to learn about that non-small cell. Or, when you break that down, if you have adenocarcinoma, you want to learn about that. You want to find people because the treatments are very, very different. The side effects are very different. So I think that is why these groups are around. And I think they're very powerful. But I do get concerned that people will feel like they don't have a community to go to. That definitely, I think about that a lot, actually.
ありがとうございます。
Thank
す
you
ご
very
く
much.
幅広い視点を持って
So
らっしゃるん
you
だな
have
と
a
思い
diverse
ました。
perspective, I
では
felt.
もうちょっと質問していきたいです。
So let me
いっぱい聞きたい
continue.
ことが出て
A
きました。
question, but I have many questions actually.
サミットの中でしょうか
Talking
ね。
about
サミットのことに
summit.
ついて聞きたいです。サミットの中で若手の研究者と
So you are supporting early
皆さん患者
career
会の方々がこう議論して
investigators, and you have a discussion with
研
them, right?
究
about their researches, which research they should focus on. That kind of a discussion are going on, I heard. Could you give me more details about this particular activity, that kind of a, collaborative system with those investigators are not very common in Japan. So tell me about it more.
Yeah, so I think that early career investigators a lot of times now they're told to work with patient advocates, but they don't learn it in school. Their degree doesn't depend on it. No one tells them how to do it, and there isn't a guidebook, but they're very eager to learn from advocates as well. They're open to ideas. They will, look outside the box a little more than others. And so I think they with the EGFR Research Summit, they come with an idea, a concept, or they come with kind of a little bit of research that they've done on something. And after they present what they're going to present, we can ask questions. And the questions that we ask as patient advocates are always different than what a scientist is going to ask or a clinician's going to ask. And usually, they're silent because it's something they didn't think about. It's not that it's, a hard question or a dumb question. I used to think it was, but it's just, they don't think on the same level that we think of in terms of the lived experience. They are looking at this exciting science. And so it's kind of, I feel like my job is to remind them that behind every data point, behind every exciting, finding is a person and a family that is impacted profoundly beyond statistics, beyond survival. And so what's really cool about it is they reach out afterwards. They want to talk more. They want to understand more, or they will literally, somebody reached out today with an email. He wants to totally redesign his protocol and wants to talk it through. And it's amazing because that's really thinking, I want to make this feasible for the people. And that is that they really are committed to that. So it works that way, and it works in other ways down the road where they reach out and they want to find an advocate and they want to understand what they can do better. And so I don't think, it's fairly new working with early career investigators, but it's really, I think, important. And again, that is our future. And so if we can help, you need both their expertise in the science and our expertise in the lived experience to make research both rigorous and meaningful and relevant to the people it claims or it's trying to help, benefit. So it's one of my favorite things to do.
Wonderful, excellent. And I would like to follow your path. I still want to ask about dashboard and like giving priority. However, the given time has passed, therefore, I would like to ask that kind of questions in a different occasion. Jiru-san, thank you for your wonderful presentation. That was really intriguing, interesting.
Thank you, and thank you for having me again. I look forward to hearing from Terri and Ken. Thank you.
では続いてですね、
Now, shall we move on to Ken-san's group? Hello, Ken.
Hello, Ken. Hello there. It's nice. Thank you for the invitation.
はい。では、ケンさんの紹介を私からしたいと思います。
I would like to introduce Mr.
続いて
Ken
のス
Culver.
ピーカー、ケンさんはです
The
ね、
next
ア
speaker.
ルクポジティブの
He is the representative
ドクターでも
of
あるん
ALK
ですね。
Positive, and he
ドクター
himself
が
is a doctor,
患者会を率いている
and
リ
a
ーダーを
doctor
務め
is
る
leading the
そ
patient's
れ
group.
はとても日本では
This is
珍しいことだと
very
いうふうに
unique
思ってい
and
ます。
very rare in Japan. Very rare in
なぜ、
Japan.
ドクターが関わったのか、そんなところからぜひ
Why
ぜひ
he
聞い
got
ていきたいと思います。
involved with the
そして
patient's
ま
group.
た
I would like to
私
ask
が
him the
こ
question.
のスライドを見た限りだ
And
と、
when I look at the slide,
とても、組織が大きいなというふう
the
に思っています。
organization is
その辺の
very
ことも
big,
聞かせていただければと思い
and
ます。
we
で
want to
はぜ
learn
ひ
about
ケン
it.
さん、プレゼンをお願いでき
Now,
ますでしょうか。
Mr. Ken Culver, please start your presentation.
Thank you. Okay. There. So again, thank you for the invitation. It was great to get an update on EGFR resistors. Thank you, Jill. I don't lead ALK Positive. I was just this past week named the executive director, but I do what I'm told to amplify and strengthen anything that our patient community needs, wants. And our mission is very simple. We're dedicated to improving the lives of ALK positive patients worldwide. Our website is at the bottom. Much of what I'm going to share with you is on our website. So ALK Positive was funded, as was mentioned earlier, in 2015 by a patient. Perhaps, Jill, for many of the reasons you said, right, searching for a community as people struggle through their life with lung cancer. Now, it's hard to know how to count how many we have, but we have about 10,000 patients, caregivers that are engaged in our community. 55, more than 55 countries. Actually, in our patient registry, we have patients from 71 countries who are participating. So today, my presentation is going to be a little different because I'm going to try to focus on things that I'm hoping we can collaborate with Japan and others. So we were founded by a patient, but we're led by a community. And I think what's really amazing about ALK Positive is that the board of directors is 90% patients and 10% care partners. So it is very much a patient-led community. We don't have a key opinion leader summit. We have a scientific advisory board we meet with through the year, but we have a patient summit. And this picture is from our patient summit in July 2025. We had 450 people there. Many of them were only 1 or 2 years since their diagnosis. It's been getting bigger every year. I think we're shooting for around 600 in 2026. But this is a very empowering and fantastic time. In addition to the patients and caregivers, we have probably 20 companies who or send their representatives, therapeutic, diagnostic companies. And then we have quite a number of key opinion leaders who come, many of whom participate in the sessions. So they're probably 70% are probably patient-led sessions, about 30% are expert-led sessions. And it's quite remarkable, and it says a lot about the founders and the core culture of our organization is being so focused on this community we serve. And it's funded by patients. So I'm not going to get into a lot of our activities today, but just to say our patients and care partners have a full calendar. You can see it on our website. Almost every day of the week, there are healing arts and education programs ongoing that people are free and welcome to join. We also have a free second opinion program We have people all around the world who apply so they can get opinion when they don't have an ALK expert nearby, like we're generally spoiled in the US and probably Japan to some degree. We fund, I'm calling it high impact research here, but I think probably as of last board meeting, we have committed to over now $10 million in research projects, and 5 of those have led to new clinical trials. One of them has sites in Europe, the US, and Japan. So we are through our programs when I'm talking to companies, we are talking to companies. We're saying, hey, we want to see this in a global context to get this trial completed as soon as possible so that if it works, it can get to as many people as possible. Kazuo, you asked me why I'm working in a patient organization. Well, it's really pretty simple. I went into research when I was a resident because too many of my patients were dying. And I thought there's got to be something better than watching people die. So I went to the National Institutes of Health and I worked there in the National Cancer Institute and lab and clinical research. And then I went to Novartis Oncology. I was there for 20 years before I retired. And during that time, I got to work on breast cancer drugs and hematology drugs, prostate cancer, kidney cancer, and with ceritinib as the second ALK inhibitor. Through that experience, I got to know the ALK community. I got to know the lung cancer experts in a very close way. So when I retired from Novartis and was presented with this opportunity, it was a no-brainer, actually. It was an answer to prayer in many ways because I really wanted my career to be as meaningful as possible. So now, the last bullet there, we're building partnerships with people who share the same vision. And much like the model that EGFR Resistors has, we partner with other groups. Frankly, I always say we'll partner and we'll talk with anybody who will help advance our cause. So Japan is central to ALK positive lung cancer therapy. I don't know if everybody knows, but in 2007, Dr. Mano and colleagues in Japan discovered the ALK fusion gene. And little did anybody know in 2007, it was going to lead to the approval of 6 tyrosine kinase inhibitors that are available in the United States, and many of these are available worldwide. And we don't want to forget that alectinib, right here in the middle, was created by Chugai Pharmaceuticals in Japan. And probably right now, alectinib is the #1 most prescribed, still probably the #1 most prescribed ALK TKI in the world. And so we are so grateful, and we're thinking, oh, that's all the more reason why we need to be collaborating. And so here are the data that was just presented at ESMO. Again, this is with alectinib, which with Roche Genentech took from Chugai. And it shows that the median overall survival is almost 7 years. And of course, this starts way before we had lorlatinib and other drugs available. And so it could well be that it's longer. I'll show you that in a moment. But the ALEX trial, the phase 3 trial, now has its final OS readout, and it's really great. And I think so many thousands of patients have benefited from that research. And then the most recent data presented at ASCO in 2024, just a little over a year ago, is this is a 3rd generation TKI versus alectinib, which is a 2nd generation. And we don't yet know what the overall survival is going to be. We haven't even reached the median PFS at 5 years. So I'm thinking, well, Dr. Wu, who's one of our advisors, told me that when he sees a new ALK patient in his clinic, he tells them they should expect to live at least 10 years. And that's now the median, right? So some are going to do longer, but some are also going to do shorter. And so we as an ALK community are saying these drugs are great. They've helped us a lot, but the job isn't done yet. Until we get to a cure, the job's not done. And I think we have the patients who progress early, and then we have those like, Jill and Terri who are way out here on, we want everybody out there on the end of that tail. One of the other things I did for our patient summit this year is we really are emphasizing clinical trial enrollment, because the faster trials are enrolled, the sooner we find out whether the drug works and the quicker it can get out to more people. And I went back and I looked that for these 6 TKIs to get approved required over 6,500 patients to volunteer and participate in trials. So 6,500 people went into experimental trial, in many cases not knowing if it was going to work, but their participation, their sacrifice, their courage transformed the ALK lung cancer landscape. So we're really grateful, and we know that our community today wants to continue with that. So our board has 4 pillars, 4 things we're working on. First, we want to drive research to a cure. So second, educate and empower patients, care partners, clinicians to improve patient quality of life and life expectancy. This survivorship and many of those great topics that Jill highlighted. We need to acquire resources, right? We can't drive research to a cure if we don't have enough money and we don't have enough qualified people to do the studies. And then finally, as an organization, we need to make sure that we have excellence in how we work, how we organize ourselves, how we grow, and how we work with our community. So tonight, in my last few slides, I'm going to focus on the top left hand, the driving research to a cure, because I think there's some opportunities for collaboration amongst all of us on this call. So one of the things that's really unique about our organization, when I joined 3 years ago, is that we are organized into 5 patient committees. And this involves about 30 patients, mostly patients and some caregivers. So there are some people that are on multiple committees. But we have these 5 committees that meet either every week or every other week. And the Research Acceleration Committee, we advocate with companies and to establish collaborative research programs. So this past year, we have multiple companies now who have decided to make ALK Positive one of their very first trials with their program. And I'll show you why in a moment. We have a clinical trial committee, and this committee, again, of patients and caregivers is responsible and needs to talk about how do we educate about clinical trials and increase enrollment rates. We know from just a recent 4th generation trial, and I should have put the data in here, but the enrollment rate for the Nuvalent 655 study was the fastest one in many years, the enrollment rate per month. And they give a lot of credit to our patients and our caregivers who were responsible for really learning and letting people know about these opportunities. So that's been amazing. And in addition, of the about a dozen grants that we've completed, 5 of those have led to clinical trials. So we really are trying to do things that it's great to discover something, but if you can't translate it into patients, then we got more work to do. Then we have a translational investigations group, and this is our own internal research group. We can depend as much as we want on universities and companies, but we don't always have, as Jill said, we don't always have the same questions or priorities. So because of patients in our group who have PhDs and MDs and MBAs and are teachers and insurance, people who are really invested in seeing this succeed and have learned about science and medicine of ALK, we work together to do our own research program to try to fill in the gaps. And I'll give you a quick example. Then we have our global registry. And then finally, we have our grant review committee. So I'm going to focus now on the first 3 of these committees. So the mission of these committees is really simple. We want to motivate, facilitate, and enable development of new therapies and biomarkers to help our patients. So we, again, like I said, we'll talk to any company, we'll talk to any university who is in to try to convince them that ALK should be a part of their portfolio, not a competition, but it's part of a portfolio. We come in and we have three priorities. One, we got to figure out how do we find persister cells and kill them off. And hopefully that'll be common to KRAS, EGFR, ALK, and others. Second, we need new therapies for TKI resistance, because in the end, that's what's killing our patients. And then three, we need immunotherapies. ALK and a couple of others like EGFR, we didn't have good responses to the first immunotherapies, the PD-1 and PD-L1 inhibitors. And so we've been excluded from lots of immunotherapy trials. And that doesn't make any sense, because why would one preclude the other? So because we have this motivation to talk to commercial companies, in last year, we met with 34 biotechs, 23 universities, and 17 pharma. And you might say, well, what in the world is a patient group saying to almost 100 different entities like that? Well, we have a 4-point plan. One, we tell them that there's a business case. One of the misconceptions about ALK positive lung cancer is that it's rare. And you could argue that it's only 10,000 new cases per year in the United States, but people are living for almost 10 years. And when you do the math, that means there's more than 500,000 ALK positive lung cancer patients around the world. So we also have looked at the revenues from Takeda, Pfizer, and Genentech, and we know that they're making about $3 billion a year. So saying ALK is too small of a market is wrong. So we have to take care of that misconception. Second, we have to advocate for the patient case. We have to make sure the unmet need is fully understood. And our patients have always been good at that. They were doing that well long before I came. And this is really, really critical. And one of the biotechs we met with, we had our Zoom with our 10 patients on there, and they all introduced themselves and gave a short synopsis. At the end of the call, the CEO of the biotech said, "This is the first time I ever met a patient." And I thought to myself, that's just wrong. How can that be? So advocacy is really important. We need to educate about the science in medicine. We have to push for trials that are based on data, not just lumping oncogenic drivers together, because what an EGFR or KRAS patient responds to, in many cases, ALK won't, or vice versa. And I'll give you an example. And then we have to change the drug development paradigm, that our patients need to be included. And when they're included, there have to be enough patients with ALK that you can make a meaningful decision. So this is a lot simpler than it looks. So what is a part of our own internal research program, we hired a bioinformatics company, because one of our patients had a good relationship with them. And we started looking at gene expression. So every little vertical line is one cell. And the higher the line, the more gene expression there is. So if you look at the very first top here of these 4 genes, you can see that these 4 genes are expressed almost completely in ALK. Very little in EGFR, very little in HER2, not a lot in KRAS. But if you go to the next one, those 4 genes are expressed almost all in EGFR. So why would you give a therapy to those 4 genes to an ALK patient, a HER2, or a KRAS patient? And then if you go to the next one, another example, here's one that happens to be expressed primarily in KRAS and the other one in ALK. The ones we're most interested in are these bottom 4 examples, and you'll recognize all 4 of those genes right away, HER2, HER3, MET, and TROP2, that are expressed in large amounts in all of the tumors in all 4 of those groups. So we're doing this because we want to identify new target genes. I mean, we can keep inhibiting EGFR, ALK, and KRAS all we want, but the tumors have other bypass mechanisms, so we have to define new target genes. Two, we have to advocate for companies, but we got to bring them some data and some confidence that if they invest in this, that it's likely to be successful. And then we need to improve clinical trials because we want to base it on data, not just on lumping different cancers together. So I'm finish up and just tell you one of the new exciting things we've done is we've launched a clinical trial finder on our website where we have a curated list of all of the trials that allow ALK positive patients around the world. And right now there are 142. And so if you go to our website and you click at the top on the clinical trials tab, you'll find this form. And you can just, so if you put in, guide me through, you go up to the upper top hand corner and you can select your language. So it'll immediately switch over, and these are the current languages that are available. And so that makes it applicable around the world to a lot of places. Then it asks you where you live, okay? Because we know that one of the biggest clinical trial limitations is how far you have to travel. So if we say, okay, we live in Kyoto, Japan, and we hit enter, what we find is that there are 11 trials within 15 kilometers of Kyoto. 6 of them are first line. 5 of them are patients who've been previously treated. Then if you go to the next one, you click on the 5, it shows you here there are 5 trials being conducted at 11 locations. So it allows you then to click here to get more information. Again, this can be in your native language. You can send an email right then. It already pulls up and already formatted. You can say, I want to know more about your trial if you think you might be eligible, you're interested. And if you're doing it in Japanese, then it's all right there for you. So we are hoping that this resource will be valuable to everybody who's working with ALK around the world. So in summary, ALK Positive is a patient-founded, patient-led, patient-funded organization, and it has been, and it's doing really amazing work. It's a privilege to be associated and working for the community. Our medical committees are active. They're pressing for new trial options, and we're working to make sure when we get them, they get enrolled. We're making progress with a number of clinical trials that are funded, increasing from one trial funded when I joined 3 years ago to more than 10 early next year. The TrialX platform is capturing a curated global trials that include outpatients. So they could be phase 1 for solid tumors, or they could be specifically designed for outpatients. And then we welcome partnerships to expand care and opportunities for outpatient community all around the world. So I'm really thrilled to have this opportunity to speak with everyone tonight. So thank you very much.
はい、ケンさんありがとうございます。はい。
Thank you very much, Ken-san.
私はですね、今ケンさんの話を聞いて、
Having heard your presentation, I have one thing that I regret. That means that time is too short. We need much more time for your presentation. Because of the limited time, I can only ask us a few questions, but may I ask you some questions?
Of course.
はい。まず、ケンさん
First of
は
all,
アルクのことを説明してくださるとき
you
に、
have explained
真野
about
先生の
ALK positive, and you referred to
アレクチニ
Dr.
ブのこ
Mano
とを
and
お話ししてください
Alectinib.
ました。真野先生はアルクを見つけた人ですよね。
So
そして
Dr.
アレク
Mano
チニブ
found
は日
ALK,
本初の
and
薬です。
Alectinib is the
そういう意味でとても私たちにとっ
medicine,
て
a
は
drug that started from Japan. In
親
that
近感を持ってい
sense,
るという
we
か、
feel very
誇り
close,
です。
and
そこ
we
に
are
対して
very proud.
触れていただいてとて
And
もありがた
we
い
are
と思っています。
grateful that you referred to it in your presentation.
Well, we are grateful. How could I not?
はい。はい。ちなみに真野先生 などは、
So,
そ
Dr.
れぐらいのサ
Mano,
ミットなどとかにお呼びになられたりしたこと
you
はあるんですか？
have you invited him to your patient group session or meeting?
We had Rohei. We had a different Japanese investigator who's been investigating. I haven't met Dr. Mano, but we had a colleague.
そうですか。もし、もう今とても
Dr.
I
とても
see.
ですけども
He is
あの
such a
何かあれば
prestigious
ぜひぜひ
person now, but
呼んで歩くの
I
誕生の
do
歴史を
hope you
なんか皆
have
さんにしてもらえたら嬉しいなと
opportunity
は
to
少し思いま
invite
した。
him
とても私たちも
and
歩くの
let
誕生の
people
時
know
とて
the
もその間野先生含め
history
て
of
研
ALK
究者が
Positive.
右往左往した
On that
のは
time,
よく聞いて
they
います。
had a
は
lot
い。
of struggle to
で
over and
は
a
ここ
lot
か
of
ら
problem to overcome. And I'm very
ではこ
familiar
こから
with
ですね、
that.
質
And
問したいと思います。
I have
あ
some
の
questions.
まず患者のその知見を探す仕組
The
みがありましたけ
system,
ども、これは日本対
to
応もされてるんです
search
ね。
for,
すごいですね。
clinical trial. You also cover the Japanese clinical trial there. It's amazing.
やはりあれは非常に需要が高いから作った
I
ものなんでしょう
believe
か。
that, the demand is high. That's because the demand for this kind of thing is high, you made this. Is that the reason you made this one?
Yes, we need to make it as easy as possible for people to get to a trial once we've inspired them and educated them so they will participate. And Astellas is just getting ready to open the trial in Japan. Okayama University. I don't know who the investigator is yet. So what I'm going to do, Kazuo, is I'm going to be sending these trial lists to you, because to each country, to ask them to make sure that what we have in the database is accurate and reflects, right? Because we want to make sure, especially like, I don't know about in Japan, but in China, they can have trials approved that don't show up in clinicaltrials.gov. They have their own Chinese approval number. So we can add any trial into this database. So if you have some trials that aren't in clinicaltrials.gov, we are glad to put them in there so that you can have confidence that people can easily find opportunities.
ありがとうございます。日本の
Thank you very
患者さんも
much.
ですね、
The
ぜひぜひ
Japanese
その会員に
patients,
なれば使えると思いますの
if
で、ぜ
they
ひチャン
become
スがあれば
the
使ってみて
member,
ください。
it's
次の質問
open
に行き
to
たいと
them,
思います。
right? We'd
あ
love to
の
use it.
私が
Next
そうですね、
question.
ケンさんの話を聞いてびっくりしたことの
That
一番一
surprised
つにで
me
すね、
having heard your
その
presentation.
組
One
織
of
を
them
きちんと
is
しよう。組
that
織を
you
エクセ
establish
レンスという言葉を使ってたと思うんですが、そうですね、
your
組織をき
organization
ちん
in
と
the
オーガナイズ
excellent
しよ
way.
うというものがあったと思います。ああいったその組
So
織だって行動するというのは、
the
どんな理念からやはり来てるものなんでしょう
organization
か。
wise, you are well established. What is the ideal behind it? What kind of philosophy behind this kind of building organization?
Well, I wasn't there when it was founded, so I can't give you all the history, but I know it's first of all, it's the passion of the patients, and how they organize themselves. It's the money that they contributed to make it possible. And I think three, there was a really forward-looking vision about how are we going to get to where we need to be. And so they created all those committees. It was a retired dentist, Colin Barton, who really helped set up all those committees. And I think it's really genius because it helps us focus people's talents and skills into areas that are really making a difference.
はい、 聞いている通りですね、そういった組織の基盤がしっかりしているからこ
Because
そ、
of
い
the
ろいろなプロ
solid
ジェクトが進むの
organizational
だなと、
platform,
私
I
自身
think
は見
you
ていて
can
思いまし
accelerate
た。今日は
various
そこからですね、またもう一つ
programs.
質問なんです。
And another question is,
メディカル委員会には
and the
30
medical
人の
committee
患者さんやご家族が入って
has
いると聞きました。
30 patients
やっぱ
and
り どうなんで
families.
しょう、普通の患者さんでも入
Even
れる
the
ものなのでしょうか、それともやはり何
ordinary
らかのバックボーン、
patient
もしくは
can
何か
join,
教育
or
みたいなものが
is there
あるからこそ、
any
やっぱり選ばれ
specific
ていくん
background,
で
a
すか。
medical one, needed to join this committee?
The only special background someone needs is a determination to help us meet our goals for the year. So no, some people are, one is one of our members is a former Silicon Valley financier. So when we talk about meeting with companies, he's always making sure we're working with companies that are going to have the money and they're viable. And he's also learned a tremendous amount about ALK positive lung cancer. So I think when someone has an interest in the medical committee, I speak with them and we try to figure out where's the best place they can contribute. And for some, that's the medical committee. For some, it's some of our other education and healing arts activities. But we don't have a rigid rule because we really want patients to be able to participate and make a difference wherever they can.
ああ、これはちなみに、もう人数はたくさんいらっしゃると
So
思うんですけど、
now you
その
have a
いろん
lot
な国
of
々にもいらっしゃい
members
ますよね。
and
そ
across
こから
the
30
globe,
人選ぶというのも
and you
大変か
choose
なと思うんですけども、
30 people
どんな
from
ふうに
among
選んでらっしゃるん
these
ですか。
patients. What is the screening process? How do you choose 30 people among these?
Yeah. Well, yeah. So people volunteer, and we always tell people we're willing to have more volunteers, and people are joining. There is a turnover, but practically speaking, because of time, we get some people from Europe who join, but most are North America, because just from a time point of view, unless we create another committee, a global committee, which I've been thinking might be a good idea, that we could have at night or your morning, that would be the way to do it. But time zones is probably the first most complicated part.
ああ、なかなか確かに。はい、ありがとうございます。あ
Thank you
と、
very
これはちょっ
much.
と最後の質問で聞
Last
いてみたいです
question.
ね。話の流れの中で、
In your
ア
talk,
ルクは希少がん、人は
ALK
少ないんだと。つまり、
is
研究がなかなかされに
ALK
くい土
is
壌があ
a
るけれども、
rare
いや、そんなことな
as
いん
an
だと言っ
gene.
て、いろんなデー
It
タを
is
集め
the
て、
general
企業に
conception.
説得して
However,
いった
you
り、
persuade
研究を促進させ
companies
るとい
that it
う
is not
活動
actually
をされてい
so
ったと
with
思
a
います。
global
そ
viewpoint
の辺は、も
through
うなんて言ったらいいんでしょう。そういっ
these
た戦略は
efforts.
どういった方が
You
考え
have
てらっしゃるんです
been
か。それは
active.
素晴らしいなと思って
This
聞
is
い
a
ています。
great strategy. And I wonder what kind of people think about this kind of strategy. Who built the
Yeah.
strategy?
Well, I worked in the pharmaceutical industry for almost 25 years before I joined ALK Positive. And I knew that when a patient group talks to a company, those people are all really motivated by the patients. But then they go back and they talk to other people in the company. And what do they say? Too small of a population, can't make enough money. Sorry. So when I joined ALK Positive, I said, hey guys, and gals, let's add to our presentation a business case to get rid of that at the very first thing. And when companies started seeing that, especially the biotechs, it changed their whole opinion. And the other thing we know through our our registry, that about 85% of ALK patients go from a first-line therapy and they end up on a second-line therapy. So if a company is developing a drug for the second line, they still see that's almost all the patients who are going to be eligible. In some cancers, only maybe 30% ever go on a second-line therapy. So ALK is different. Maybe that's true of the other lung cancer subtypes too. But I think that's a really important point. And so it has to have a business case, it has to have a medical case, and most importantly, it has to have a patient case that brings it all together.
なるほど。今おっしゃっていたことというのは、
What you're saying
肺がんのドライバー遺伝子の各タイプ
is
の
a driver gene
患者会
type
だけではなくて、多分
patient
す
group
べてのところに
only,
共
not
通する
that
お
is
話なのではないかな
common,
と思って
not
伺っ
only
ていま
for
した。
driver
とて
gene
も参考になります。ありがとうございます。
patient
はい。
group, but
時間が
applies
来ました。
to other type
ケ
of the groups.
ンさん、
Thank you
こ
for
れ
your
で
informative
ケンさんの部
report.
分は終了です。
So,
ありがとうございました。
thank you very much, Ken-san, for your great
Thank you.
presentation and Q&A.
Thank you for the honor and privilege.
はい。続いて今度は
So
3
let's
人目の
continue. The
演者
third
の登場です。テ
presenter,
リーさん、お願いできますでしょうか。
the floor is yours.
テリーさん、どうもこんにちは。
Hello, Terri.
Hi, good evening. Thanks for having me here tonight.
Yes.
では次はテリーさんの、
So
患者
next
会の紹介
presenter
をして
is
もらいたいと思い
Terri-san
ます。
to talk about her patient group,
創
KRAS
設者
Kickers,
であ
the
ります。
founder of
そ
KRAS
して、
Kickers.
もうこれは公開されているの
And
でいいと思うんですが、
it is public information that KRAS G12D
G12D という変異を持つ患者さんで
mutation
もあります。
holder she is
そんなテリー
also.
さんが、
And
行っている KRAS キッカーズという、患者会をぜひ紹介してください。
So
よろ
let
しくお願いします。
please introduce your organization to us. The floor is yours.
Thank you so much for having me here tonight. All right, let me share my slides. Okay. As you said, my name is Terri Conneran, and I live in Charlotte, North Carolina, in the United States. And I am so happy to hear you and to be able to see you all tonight. Let me tell you about, can you hear me?
あ、テリーさん、
テリーさん
ですね、全画面になっていないようです。
So you, your
あ、
screen
なりまし
is
た。
a bit
大丈夫
small.
です。
Yeah, it's now
お願い
changed.
します。
Thank you.
Okay, great. Okay. So, so I'm Terri Conneran with KRAS Kickers. I'm going to just talk a little bit about how I landed here and what's important. I've got a very different perspective than both the amazing Ken and Jill. And so I'm bringing a different perspective to what we've got going on. And I'm calling this biomarkers and belonging. In 2017, I was diagnosed with stage 3 lung cancer. This was actually shortly after the diagnosis, with the kids, who have now grown up to be a little older, my husband. During this time, I, like anybody else, wasn't expecting to have a lung cancer diagnosis, and I didn't know what to do with it. I have no medical background. I have no education in this particular area. I never worked for a pharmaceutical company or anything of that nature. So I never had the benefits of somebody like, say, like Ken or many of the people, or even as much as the wisdom of Jill Feldman. Jill was exposed to seeing her family members get diagnosed, and she was in a big city, and she had no fear as far as learning about it and getting involved in finding out about her lung cancer. I didn't feel that way about it. I was scared, and not just scared because I had an illness. I didn't know what to do or what I needed to know about. And all I knew about cancer is that people made a difference. You took a drug and then you either lived or you died. And then to do something like advocacy was just took a long time and nothing ever came out of it. I didn't know anything about the science. I didn't know anything about background of it. Well, it all ended up kind of changing, and that's how I'm ending up here. So just to let you know, I'm still going strong. I was diagnosed stage 3. I've had 5 different recurrences over those since that time. And I now have had no evidence of disease for about 4 years. KRAS is the most common in general in lung cancer across all cancer types. But it's just a mutation, and I have not been able to benefit from anything like any sort of like a specific targeted therapies like they offer with ALK or they offer with EGFR. I've just been through surgery and chemo and radiation, kind of just like your average run of the mill. We don't know what else to do if you get this kind of a treatment. I'm still here. I'm still here and I'm still kicking, actually. Just so much so that I now have 2 of my kids are married, and the third one we think is going to be happening soon. So we're still going strong. Over the period of this time, if I was diagnosed today with what I had done, I had a better chances of living longer and living even better. So the fact that I even started to get here is really powerful. Let me tell you what happened and how that landed here, because I'm not going to talk to you about how important clinical trials are. They are important. I'm not going to talk to you about the importance of screening and scanning. You're here for a reason. You probably care about having, probably you or somebody else you know cares about the lung cancer that you have or you're being exposed to. What I want to encourage you about is asking questions. I was diagnosed. I went through treatment. Then I got connected with other people that had lung cancer. I didn't meet somebody as high up and as educated as Jill, but I met a lot of other people that were like her, and they knew a lot about their cancer. And in knowing about their cancer, it made me learn that it was okay to ask the questions. So I asked my doctor what kind of cancer I have, like specifically within the lung cancer. Well, long story short, after a couple of recurrences and a number of times of asking, I finally found out, because I asked the right doctor at the right time and got a copy of the report, that I have this KRAS. Now, what does a KRAS mean? It means one treatment may or may not work better for me than another. Let's see if we do this. There we go. So I had already heard about all these other groups like the ALK group and the EGFR, and there's a number of other ones as well. And I wanted to connect with other people that had what I had. So I thought, well, it's easy enough in social media. This was in 2020 and COVID was getting busy. So a lot of us were starting to stay home. I started a Facebook group called KRAS Kickers. And the whole point of it was to do what those other groups were doing. But we weren't funding research. We didn't want to go and figure out policy, didn't understand everything, but we want to know what it is we need to know, what I need to know for me, for my body, and ask questions and hear from other patients. And it felt like a really safe place to be able to go into a Facebook group and have a conversation with other patients and hear what they have to say, hear what they have to do. I'm not going to lie. It's embarrassing having cancer. It's really embarrassing. It was something that we were kind of truthfully encouraged to be rather stigmatized about, right? To accept that something caused it, or maybe it was bad genetics, or maybe it was the smoking, or whatever it was, that it did something to it. And so the first problem I ran into, I had to be able to open my mouth. I had to not have the fear. I need to open my mouth. First, I asked my doctor what I had. Then when I found out, I started connecting with other people that had it too. And you know what I learned? As I've learned that I needed to know more, and that my questions were the same as what they had. I didn't want just like somebody to just tell me they were sorry. I wanted somebody to understand me from the same position that I had, also as a patient. Realize that it's their body, this is my body, and we have this common enemy. We have this common enemy. It doesn't matter where you are in the world. Cancer is horrible. If it's in your family, it's really horrible. If it's anybody you love, terribly horrible. So what can I do? Well, simply, this group we started ended up turning into a nonprofit because that's the only way that we were able to connect in a business manner with the other groups that we needed to work with. And instead of using patient empowerment and educate, what we did is we came up with an acronym for our group based on the KRAS: knowledge, research, advocacy, and survivorship. It's really about understanding myself, my cancer, my illness, because it's not always just a one-part equation. It's my family, it's all those around me, and how we can kind of work with that together. So we wanted to be able to have the informed choices. Well, at this point, KRAS, which again, doesn't even matter what you know or what you don't know. What mattered was that I had it and I needed to know more about it. So a little digging, a little bit more digging. I found out all the research and the science that goes into it and how incredibly important it is. And so KRAS Kickers became a patient group that wasn't focused on just lung, because KRAS cancers are in the 3 deadliest cancers. And they're the most common in all 3 of the deadliest cancers. Well, I'm going to, pardon me for using these. I'd hand them to everybody if I could. These are socks. And the reason we use socks, because we were going to kick cancer's KRAS. But the reason I use the socks is because the colors on here are colors that we use to represent the different cancer types. And these socks are the 3 deadliest have the 3 deadliest cancer colors. White's lung cancer, blue is colorectal cancer, the purple is pancreatic cancer. The most common biomarker, the most common mutation in all 3 of those deadliest cancers is KRAS. So how could I exclude anybody when I want to have a community of all people that can be working together to literally kick cancer's KRAS? If you ever see me, I'm happy to give you a pair of socks. But the whole reason we have the socks is because it's a symbol of your humility and be able to accept and face what you have, but also how important it is for each of us to be walking alongside of each other in this journey through our cancer, through our illness, because it's not just a one and done thing. The KRAS Kickers ultimately got started, and how we really connect with other patients is we do webinars, the same as the other groups. We do webinars. You'll see us in our YouTube videos. We have a Facebook group. We're doing in-person session. If you can get to San Francisco, we'd love to see you. We're doing one in San Francisco in February, and I'll show you the link to that later. But what was really important was when I found out that there was something that was driving this, and I didn't have the education, and I didn't even know how to ask the question. I needed to get permission from and find ways to give myself permissions to be able to hear how to ask it. And I heard those things from groups like the ALK group and groups like, and people like Jill Feldman. You have no idea. Jill Feldman's a big deal. Ken Culver's a big deal. They're very busy. They're very engaged. And how are they engaged? Is they're helping the patients on the front line. They have different types of mutations depend upon what type of cancer treatment you're going to benefit from. There's only 2 small cancer treatments that are available for those of us that have a KRAS. My specific type doesn't have any. The ones in pancreatic don't have any. The colorectal, next to nothing, same as lung. So there's a lot more coming. And we're hopeful that there's going to be more in the future. And as a result of that, as patients are finding out what they've got going on with their KRAS cancers, they're looking for trials. They want to look and understand. And when I found out simple things, like this little tiny cancer DNA thing that was happening, it took about 250,000 times 250,000 times for this little tiny thing to keep making a mistake, for it to be seen on the tip of one hair. That's a lot. It's not like I fell asleep yesterday and woke up this morning and had cancer throughout my body. It was slow growing. And that made me ask more questions. And it made me want to stand alongside of my doctor and learn what I needed to know. It's my body. I wanted to ask it and get to find out what's what. All right, so I'm slacking on the slides. There we go. What I call those are KRAS holes. Not sure if that's going to actually translate properly, because it has a double entendre meaning. But a hole is any gap, any barrier in any sort of healthcare literacy or equity that you're looking for yourself. If I don't understand it, it's a hole. Not knowing what it is I need to do, it's a hole. It's a gap. It's a barrier. It's a problem. I want to feel comfortable and confident. I trust my doctor, but I want to be able to understand what's going on with my body. It is, after all, my body. I leave, they stay there, I go home. So the KRAS hole at the end of the day is me asking the questions, and I need to be willing to step up and ask the questions and learn alongside of my doctor. This is something that I think many patients don't really realize how important it is to do, and it's okay. And a lot of what we do within our Facebook groups and what have you, or even within the webinar sessions, is asking the questions, hearing how those questions are being asked and how they're being heard. And that's okay. Now, I'm not going to lie to you. In fact, I'll never lie to you. What I will tell you is that from learning one thing, I wanted to learn more, and it made me want to learn more. It made me want to learn more. And so eventually I managed to learn how to get myself get to see a lab, see these things, learn the experts, see what kind of connections actually happen, to be able to understand what that is at a really small molecular level. And if I could understand it just in a molecular level, it made me feel more empowered. It made me feel like I could do this as a patient, as a person, as a mom, as a wife, as a maybe one day grandma. It gave me what I needed to know, because I needed those little pieces of information to be able to move forward with it. Oh, there we go. Oh, is it no KRAS holes? Hopefully we covered that. And again, these are fun stickers. And the reason we have this out is because I want to make cancer understandable, where a patient can understand it and you're not afraid to ask the doctor and learn alongside of them. We already talked about how patient empowerment and KRAS Kickers is a patient empowerment group. We're in 117 countries worldwide, and we use all the things that we really are looking for in order to be able to move our organization and move individual people better. It's not about making this organization better. It's not about making it bigger. It's about patients and helping people, because we are people. They're just looking for knowledge. It doesn't matter what it is. I want to understand a little bit about it. I want to understand the research, what that looks like, what that means to me, what that means to tomorrow, what that could mean for my children, my future, my legacy, what it means to the community as a whole. Advocacy is how to ask that question without offending the doctor and being comfortable with that, and then knowing what it is I'm listening for. And as you've already heard, so many of us are living. We're living, and in living, that means there's survivorship, and we're ongoing survivors. I'm a 9-year lung cancer survivor. I never thought that would be like a thing. I thought that you just got diagnosed and you went away and you just died. I had no idea you actually could live with something. That's a cancer. And I just knocked that off. I think I just knocked off my thing. I don't even know if I'm going to be able to move this thing. I just broke my mouse. Okay. Ha! I just broke my mouse. Hang on a second. Well, technical difficulties. I knocked my mouse off my desk. There we go. So KRAS kicker is the same with everybody else here. You've heard about how important research is, and research is incredibly important. How important clinical trials are. Yes, they're important because what they're working on today are for treatments for tomorrow. But how do you find a clinical trial? What is a clinical trial? How do you know what that is, and how do you know if you qualify and what that means? Well, we took this challenge on. We got an IRB, we did the whole thing you need to do to make this all happen. But we want to understand as a patient, how do you get access to us and how to get information? Although our organization is in 117 countries worldwide, and we have folks throughout Japan, throughout Asia, along with, I don't know, all the other 116 countries out there as well. We're trying to find out how you can get into those trials and what that means for you. In Japan right now, we pulled this up tonight. There's 177 specific KRAS lung cancer clinical trials. 177 current lung cancer KRAS clinical trials. The non-specific, meaning you just have lung cancer, but it's not targeting just a specific type of a KRAS, 109. So that means you're just diagnosed with a cancer, a lung cancer, and you're not sure what it is that you need. There still might very well be a trial out there. Trials may not even be the right thing for you. That's something you need to discuss with your doctor. And that's one of the things that we've all learned. Like I talked about how important it is that you ask the questions. Okay. I can see we're running short on time, and I want to make sure that we give time for the panel, because I think the panel is going to be the part of the night. So let me tell you about tonight, about what we're doing in February in San Francisco. The researcher that found the way to target this KRAS, which was 40 years and it was completely undruggable, is in the University of San Francisco. So we're going to be doing a conference there. We're going to be touring the lab. We'll be connecting with other patients. We've got doctors from lofty positions that are coming in. And we have received some funding so that we can help provide scholarships to get patients to come and attend and hear what this is, see what this means, and see what this looks like. And I am going to end there because it is, if I can see how to stop sharing my screen. Again, I apologize. This is a brand new computer for me, so I'm going to stop. All right. Looks like I stopped sharing. Well, I couldn't have had much more go wrong, so there's that. So thank you very much for your kindness and your courtesy in tolerating my dropping my mouse and everything else.
ありがとうございました。そうですね。
Thank you very much.
今、テリーさんの話を
So
聞いて、
having heard your
もう早速
presentation,
質問したいことがいっぱい溢れてきたの
many
で、
questions,
質問していいですか？
popped up in mind. May I ask questions?
Oh, please do.
どうぞお願いします。
まずテリーさんは
First of
お医者
all,
さんとのコミュニケーションがやっぱり大切なんだ。
you
そこに対し
said
て
communication
どんどん
with
質
your
問を
doctor is
ぶ
really,
つけて
really
いくよう
important.
に
You have
と
to
いうよう
ask
なこ
questions
とをお
not
話しして
once
いまし
but
た。
many times,
コミュ
right?
ニティでは
So
そういった
within your
ことを
community,
すごく大切にしているというか、
I
どのよう
think
などんなふうに
how
患者さんには
do
その
you
ことを伝えているんですか？
communicate that importance with your members in your community? How do you communicate?
I think a lot of times it's just within like the Facebook groups or even from doing their webinars when they're asking the questions, or say, for example, let me give you two examples. One example is if I'm doing a webinar and I'm interviewing a doctor, I'm asking the question of the doctor, I'm repeating the question back. And so I'm kind of modeling how to do that. And when you're modeling how to do that, it's not always what is the right question to ask. It's what information am I listening back for? Because I could get a list of 25 great questions to ask, but I don't know if they gave me good information. So there's that part of it. And a lot of times it gives people the confidence to ask the question and know what they heard and know what's important out of what they heard. The other thing is within the course of our Facebook groups, which is, it's an open forum, a social forum. And in our social forums, people are asking each other, like, kind of like, is this a normal thing? How would you ask this question? What is this in this way? And so where you're getting more of a level of confidence and comfort in what it is that's being said, in addition to how you can phrase it and feel comfortable with it. For example, one of the most common questions we get asked all the time is one that I was scared of. I was scared as a patient to get another opinion from another doctor. And hearing so many other people say, well, yes, it's okay to get a second opinion from another doctor, because I don't want to make my doctor mad. And then hearing how to say it and in what way to say it. And then what is the process around it? And it changes a little bit for person to person, for sure. But just knowing that gave me permission to be that person to ask that question.
なるほど、ありがとうございます。
I
確かに
see.
そうですね。
Yes,
ロー
I
ルモデル
agree
があ
with
るとい
you.
うのは
So
とても大
it's
切か
really
なと
important to
私
learn
自身も
from
思いましたし、
a role model
そ
like
こで
you.
ちょっと今日本とアメリカの文化の差
So, and
みたいな
then
ことから
there may be
質問をし
some
てみたいと思います。
cultural difference between US
よ
and
く日本
Japan.
人
So my
はシャイ
question
だ
is
というふう
related
に
to
言われま
that
す。
because
なので、
Japanese are shy.
お医者さんと日本人の
So
患者の関係は
when
な
it
かなか
comes
で
to
すね、
relationship
上下
with
関
doctor
係
and
が
Japanese
すごく強いか
patients,
なというふう
it's a
に
kind of
思
a
ったりしています。
kind of a
ですが、
there
ア
is
メ
a
リカはどうでし
barrier
ょう。アメリカ
between
人、
the
私
two.
から見る
There
ア
are
メリカ人
some,
は、
you know,
とてもやはり自分の意見をしっかりという、そういう
uncomfortable
文化
relationship
であるような気が
because
します。それでも、やは
doctors
り
are
お医者
superior
さ
than
んとの
patients, some
やり
people
取り
think.
には、
But in the
基
United
本
States,
困るという
you
よう
don't
な、
have
な
any
かなか難
issues
しい
with
壁というもの
communicating
は
with the
存在す
doctors.
るんでしょ
Don't you
うか。
do you feel any barriers when you communicate with doctors?
You know, that's a really great question. And I actually I'm really excited to get the chance to answer this. I don't have anything in the medical background, but my degree is in international business. And one of the things I studied was Japan. I love the Asian countries. And so it was one of the areas of focus I studied a million years ago when I was young. And the respect and honor that is expressed through the Japanese people is so much better than what it is with the United States. Okay, it is definitely better, but you're much more shy, you're much more respectful in a very good way. And yet it's still your body. And it's okay to ask the question in a respectful way. That doesn't mean every doctor's going to hear it in a respectful way. There's people are that way. But I do think if you can practice it and articulate it with somebody else within your community, okay, somebody like you, for example, how do I ask this question? What is it I would say? And what does this look like on the other side? Because the doctors are so, in general, they all have studied so much and they're all so wise in their ways. A lot of them really enjoy teaching you. And so you can come alongside and learn with them, like hear it from them. Okay. It's not, I'm questioning them. I'm learning from them and kind of more of a student of my own illness.
はい、ありがとうございます。
Thank you very much.
では、次の質問に行きたい
So
と思い
let's
ます。
move on to next question.
KRAS というと、
Talking
今
about KRAS,
私自身の感覚では、
in my
もう
mind,
一番ホットな研
it is the
究領域
hottest
のような気がします。
hottest
ものすご
study
く研究が
area. The
進んで
KRAS
い
is
ますよね。
study
だ
for
からつまりなか
KRAS
なか今ま
is
で難
really
しかった。で
exciting
も
now. In
今
the past, it's
その
been
研
very,
究
very
が
difficult, but
すごく
it's a
注
kind
目
of
を
hot
浴びて、
topic and
そして
attracting lots of attentions.
テリーさんが持っている 12D という
And
タイ
your
プも薬が
12D
今は
type,
ないですよね。
you don't
た
have
だ、
any
こ
specific
れ
drug
だけ
for
こう研究が進んでいると、
this
そ
12D
のう
type.
ち
But
どうでしょうかね、新薬
research
も
is
たくさん
advancing.
出てくる、
And do
そ
you
ん
think
な
there
希
will
望は
be
持ってもい
solutions,
い
new
ものなんでし
drugs?
ょうか。
Can we be hopeful in the future for your type of disease?
Oh, yes, absolutely. And there's going to be a lot more solutions. There are some solutions now. They're just not targeting just that one cancer type. Okay, so for example, something like, say, chemo or immunotherapy, different types of treatments, radiation or surgery, it doesn't always matter what type of mutation you have. And I've been through most of those treatments, and hopefully I'll never need another treatment, right? That is my hope. But there are things that are coming and they're being studied right now in the labs and in research and going through different clinical trials. I don't have that slide up in front of me, but there are specific clinical trials specifically for KRAS G12D in Japan and in the United States and all over the world and all over the world. I think there's like 3,000 clinical trials across the panel of all of them. Now, the 3,000 is kind of like not 3,000 different ones because it depends on the locations, but there's many, many trials that are being explored, and there's even more coming. And when you heard, like, say, Ken and you heard Jill talking about biotech companies, what biotech company is, it's before it actually gets into a clinic, before it actually gets to a patient, they're studying it in the lab and seeing, is this something that could possibly work before it starts moving forward and then starts getting into the patients. And so it's not necessarily like one of these big, huge pharmaceutical companies. And there's still a huge process, and I don't know anything about the approval process to get the drugs to actual patients in Japan. And I'm not going to say I know anything. I know nothing about it. But I do know that as the trials go through them for a patient, as you go through clinical trials, the trials help figure out to make sure that the right patients are getting the right medication so that later on, when other people are diagnosed with cancer, because they will be, when other patients are diagnosed, then they have a better chance. And we're living today longer because of all those clinical trials and all the other research that's been done before. So is it coming? Absolutely. There's so many different ways of targeting a cancer. It's not necessarily just like that one specific KRAS G12D. It could be up and down different cancer pathways. It could be different ways. And I could bore you silly, but I'm not here. I'm not a scientist. I can bore you about it. But you know what? When it's my body and I get all excited about it, somehow it's not boring. I was never a very good science student until I got cancer. Now I really care about my own biology and about the biology of cancer. And I think if there's nothing else, that's kind of like one of the big takeaways, is that we've learned that by just me caring about it, it gives me a motivation to live longer and do better and know what's coming. Because if you know what's coming, it makes it easier to get through today. You're going to be able to kind of move forward with it. So it's a long haul, but yes, there's so much coming and there's so many different options and so many different things coming for all sorts of cancer patients. And so I hope that they're going to keep going. They're going to keep doing it. And whoever is listening to this that has lung cancer, or they know somebody has a lung cancer, I think it's really important to know it's okay to, first of all, be scared, and it's okay to ask the questions. Don't worry about how you got here. You have what you have, and you need to figure that out and be comfortable with that.
Thank
you very much.
時間が来ました。テリー
So
さん、
time is up.
今日はありがとうございました。
Terri-san, thank you for your presentation.
では、ここからですね、
Now, from now on,
お
for
三人の
about
方
10
々に出て
minutes,
きていただいて、
we would like to
パ
have
ネルディスカッションを
a
したいと思
panel
います。
discussion
3人の方
with
々出てきて
three
いただけますでしょうか。
presenters. So, all of you, please, appear.
ケンさんいかがでしょうかね。はい。はい。ありがとうございます。あ
Thank
とほん
you.
の少しの時間ですけど
We
も、
only have limited time,
私も含めて4人で、
including
ディスカ
myself,
ッションを少しできれ
four
ば
of
な
us
と
would like to
いうふうに
have
思って
a
います。
discussion.
まず、お一方ずつに
First of
私か
all,
ら質問さ
I
せて
would
くださ
like
い。
to ask question to each
ど
of
うも
you.
皆さんの患者会にですね、
it seems that
日
your
本人
patients
が
group
参加している数が
have
少ないようなんですよね。
very few
皆さんの
Japanese
患者会に
participants
日本人が
in
参加
in
す
their
るため
group.
にはどうすればいい
In
のか、
order for the
そこから
Japanese
ちょっと簡
patient
単に
to
一つずつ
enter, I mean
教え
to
てもらってもいい
join
でしょう
your
か。
patients group,
まずジルさんからお願いできます
how
か。
can he or she do it? Jiru-san, can you start? How can Japanese join your group?
Thank you for bringing that up. That is a very important question. Our group is open to everybody, but there are barriers because we don't have translation services right now. So if people wanted to join our group, they could go to the website, which is EGFRcancer.org. And it's being totally redone right now, but there's a place to join, or to the Facebook group. We do have some people in the group that speak other languages that help other people, but not specific necessarily to different countries. So that is definitely something we need to work on.
はい、ありがとうございます。ただ私も
Thank you very
皆さん
much.
の患者会には、メール
I
で登録していたりしています。
register
参加しています。
by
その時に
email
翻
to
訳、
your
例えば
group,
Facebook であれば翻訳のボタ
but
ン
we
が
can
一つ押せば
use the
できますので、
translation function of
日本人で
Facebook.
も参加できやすいかなと
So I
私
think
自身は思ってい
nowadays
る
it's
ところです。
easier to
Oh.
join.
はい、
Okay.
So I
That's
think personally it's easier to join
はい、ではケンさん
nowadays.
のところに
How about Ken-san?
参加するためにはどうしたらよろしいですか。
For Japanese patients to join your group, what he or she can do.
So we don't have any kind of formal membership. So people, a lot of our patients are interacting regularly through Facebook. But what I'm really excited about is I met Mami in Japan, who's starting an ALK group. And so we are planning to work together to address that exact question.
はい、ありがとうございます。今お話に出てきた、マミさんというの
So
は
Mami-san,
カナダマミ
she
さんという日
just
本人の方です
referred
ね。
to
ア
as
ル
a
クの患者さんです。
Mami
ケン
Hanada,
さんと
and
仲良くなって日
she's
本
a
でもアルクを
patient
盛り上げよう
who
としてい
belongs
る
to
方です。
ALK,
方です。
who is trying
よ
to
り
make
つながり
ALK
がこれから深くなっていっ
active
て
in
日
Japan,
本も
hopes
コミッ
that
ト
the
していく、日
relationship
本も
will be
コミット
deepened
してい
and
けるように頑張りた
hope
いなというふうに
that
思って
the
います。
Japanese part will be also
ありがとうございま
get
す。では
bigger and
続いて
more
テリーさん、
excited.
テリーさんのところに参加する
Now,
ために
Terri-san,
はどう
in
したらいい
order
か
for
教
a
えていただけ
Japanese
ますか。
patient to join your group, what he or she can do?
We encourage people to join. We do have people that are from Japan as part of the group. Our Facebook group, you have to answer the questions in order to join the group because we don't want anybody from a pharmaceutical company. We don't want like healthcare providers or somebody like that. This is specifically for patients. We have an open policy when it comes to like our YouTube videos that so you can just subscribe and follow. You can go on the website and get access to all that information or see any of the upcoming things that we have. So we need more. So join.
はい、ありがとうございます。はい、
Thank you very
ここ
much.
からですね、また皆さんに、ちょっと質問していきた
I
いと思
want
い
to
ます。
ask a question to each of you,
皆さんが日本の患者さん、もしくはアジアの患者さんで
Japanese
もい
or
いんです
an
けども、
Asian
そういった
patients,
方々
when
と
you think about them
コラボレーションしていく、
and
そ
when
ん
you
な
want
アイ
to
デアというものは
collaborate
何か皆さんの中にご
with
ざいますか。
you, do you have any
ぜひ、
idea to do so?
こんなことができるといいねっていうような
If
次
you
の
have
ネクストア
any
クションを
idea
教え
that
ていただけると
wishes
嬉しいなと思いま
as
す。
a next step
はい、
in
では、また
collaborating
これ
with
もジルさ
Japanese
んか
or
らお願い
Asian
できますでしょうか。
patient, will you share it with us? Jill-san, will you start?
Yes, this is definitely something I've been thinking about for a while because EGFR lung cancer is the highest, number of people that get the diagnosis are Asian. And so yet our group doesn't represent that. And even in the United States. And I know, you were talking about earlier how people can be shy and don't necessarily want to, get involved. So there are a couple of patient advocates that I've spoken with. And one of the goals is to really figure out how we can engage Asian people from not just, Japan, but all over the world globally and create in other communities as well. We don't have a lot of Black people, and Black people get EGFR, and also it's more prevalent in the Hispanic population or the Latino population. So but that is one thing that we would like to do, definitely. And for different reasons, for educational resources, for research purposes, for community purposes. And so if anyone wants to help with that, then they can definitely reach out to me. And that will probably start working on in like the beginning of March of next year.
はい、ありがとうございます。そうですね。EGFR に関して
Thank
言
you
う
very
と、
much. Relating
私た
to
ち東アジアに非
EGFR,
常に多いですよね。
there are
の
many
半分ぐらいは
many
EGFR
patients
です
who
から
are
ね。はい、
diagnosed
とても
EGFR.
多いです。なの
About
で、
half of
この
the
力を一つにまとめていくと、とても大きなこと
carcinoma
ができるんじゃ
cancer
ないのかな
patients
と
are
私自身も思っています。ぜひま
EGFR.
た今後
And I think
コラボレーションの機会を
there's room
私も
for
考えていき
me
たいと思います。よろ
to
しくお願いし
do
ます。
something. So I will keep this in mind.
Please. And I forgot to mention the other thing is I would love that. But the other thing too is we know that family history is the highest risk factor in the Asian population. So that is another very important project that needs to be addressed. So yes, let's chat.
はい、ありがとうございます。とても大切ですね。日本の皆さん、
Yes,
あまり
that
知
is
らな
very
いかもしれないで
important.
すけども、
Japanese
家族
people
性
may
遺
not
伝する
know
肺が
very
んというもの
much.
が
There's
あり
a
ます。それ
hereditary
に関してまだ
factor
研究は進めていない。そして
for
あんまり進
lung
めてない。
cancer.
それをジルさん
Research
自
has
身が
not been
進めよ
done
うとしてい
very
るところ
much,
もあります。
but
そこに関しても議論
Jill
を
san
深めていければいい
herself
なというふう
trying
にと
to
ても思っています。
drive
あ
the
りがとうございま
research,
す。
and we'd like to deepen the discussion about it going forward.
次はでは、ケンさんお願いできますで
Ken
しょう
san,
か。
will you share?
Yeah. So 3 things. One, patient to patient, like we're starting with Mommy. Number 2, when we talk to companies, we're talking about starting trials around the world, just like the new trial with Astellas has Japan, France, United States. And then number 3, I need to meet Dr. Mano.
はい。真野先生、
Yes,
そうですね。花田さん、
that's
花
right.
田真美さんの
Mami
活動を
Hanada,
通じて、私たちも
through her
ど
activities,
んどん情報を入れていきたいと思います。
we'd
それ
like
から
to
真野先生は、
expand our knowledge
多分
and
私も
then
連
get
絡
more
取れると思い
information.
ますので、
And I think
連
I
絡取れるか
can
ら、
get
すご
in
く今偉くなってる
touch
んですけ
with
ども、
Dr. Mano, although he is very
アルクの患
prestigious
者会
now,
が、
but I think
海
I
外に
can
こんな
tell
にで
her
きていて、
that
あ
there's
なたを呼んでるよ
ALK
と言えば、
patients
一目散に
group
駆けつけてくれるんじゃ
overseas,
ないかなと、
and if
私自身
I
は思いま
convey
す。
this
はい。
message to him,
ありが
he
とうございます。
will be willing to, meet you.
Fantastic. Thank you.
はい。では続いてテリーさんお願いします。
Next, Terri-san, please.
There's always an opportunity, but the Japanese people know what it's like to be Japanese. I do not. And so I think part of it is we need to start opening the dialogue and having open conversations about different things. For example, I'm part of a committee through the International Association for the Study of Lung Cancer. And they're very much being very intentional. In fact, I was going to reach out to y'all. They're looking for somebody to read something to make sure that it makes sense in common Japanese. It's already been translated by a professional. And so now they see somebody who wants to be able to read through it. And so part of it is getting the nurses and the clinicians involved so that they can encourage the patients to step up. And when it comes to research, you have the best ideas. You know your beautiful place. I do not. And so have the conversation and open it up to have the dialogue. And when we start having reports and we start seeing things, that's when things really make the difference. Ken touched on it. Jill's touched on it. And I'll tell you for sure, I've met a number of researchers through the years. And what happens is you sit down and you have a conversation with them. And I'm pushing back on something that I know is just true as a cancer patient living with it that never crossed their mind. Like how inconvenient it may be, something may be, or how we're doing something without anybody thinking about it because it's just standard procedure. So opening our mouths and talking about it, and I think that's the most important thing, is doing what you're doing right here. Sharing the information, sharing the knowledge, and being able to bring the beautiful community together.
とても素晴らしいメッセージありがとうございます。
Great message. Thank you very much.
では、皆さんすいません。時間が
So
来てしまいました。
unfortunately,
最後に
we are running out of
3人
time.
の方々から
So from
一言ずつ
before we
今日の
close, I'd like
最後
to
のコメントをい
receive
ただいて
last
終わり
comment
にできればな
from
というふう
each
に思います。
speaker today
最後一言いただいてもよろしいでしょうか。
before we
では
close.
ジルさんからお
So
願いし
first of
ます。
all, Jill-san, over to you.
Yes, first of all, I want to thank you again for having me. But my final message is that we are in this together, that we have differences globally, but truly we are all experiencing the same thing. We are all working towards the same goal. And I've seen it happen. I was part of it with Africa. We can definitely make it work. And we're better together. And I think collaborative efforts is the only way we're really going to move the needle. So I look forward to working with you in the future and everybody else in Japan. So thank you.
ありがとうございます。では、ケンさんお願いします。
Next, Ken-san.
Thank you. I've seen that the ALK Facebook group saves people's lives. And I was meeting with an ALK patient in Nairobi, Kenya, and he said until he got in the Facebook group, he didn't know people could live for years. And he couldn't tell his employer because if they heard he had lung cancer, they'd fire him because they thought he'd be dead in 2 days. And it's such a powerful reminder. And there's a lot of people out there who really need the collaboration, the camaraderie, the expertise, all the different things that patients bring, that without it, they may not live nearly as long, whether it's the right medicine or not. So however, we should use every means possible, in my mind, to work together.
ありがとうございます。
Thank you very
では
much.
テリーさんお願いします。
Next, Terri-san.
You know, what can I possibly say to add to all that? Other than the fact that it literally, like the organization's called, One Step, Lung Cancer, it's literally one step, but it's all of us together, walking together, and we will make a difference across all cancer types, whether it's lung cancer or whatever evil cancer it is. We're going to do this because you guys are all doing your part to make a difference where you're standing right now today.
ありがとうございます。
Thank you very much.
皆さんから最後のコメントをいただきました。
So thank you for your closing
日本
comments.
の 患者の方々、見ている方
For
々、
Japanese
どんな
patient
風に感じられま
watching
したかね。
this live
また、
streaming,
医療者
I
の方
was
々、
wondering
製
how
薬
they
業の方
felt.
々も
The
これをご覧になって
pharmaceutical
いるか
companies
もしれません。
people and maybe
ここから
HCPs
次の一歩が生まれること
are
を祈
looking.
って
So I
終わ
hope
りたい
this
と思います。
session
本
will
当に
lead
皆さん今日
to
は
next
ありがとうご
one
ざいました。
step. Thank you very much for your participation today. Thank you for very much for your collaboration.
はい。あ、じゃあ皆さん、バイバイということ
So
で、
let's
乾杯の方ありが
close
とうござ
by
います。
waving
じゃ
hands.
あ、米田さん終わりです。切って
Thank
いた
you.
だいて。
That's all. Bye bye.